Yeah. Okay. Good morning. Without wasting time, we'll move ahead with the management of traumatic brain injury. As usual, these are all student-based programs, so we always start with the case and we try to stick up with the case. As the case moves, we'll see how we are managing our patients and what one's supposed to do in ideal situation. Like this is a 40-year-old gentleman found unconscious after a possible hit and run road traffic accident. He was brought to the emergency department. GCS was 6. His pupils were 4 mm size, bilateral equal and fixed. He has a CSF autoria. Heart rate was 42. Blood pressure was 168 by 108. Primary survey revealed there is some rib fractures, 3rd to 9th on the right side, and no evidence of hemothorax, pneumothorax, or hemoperitoneuria. And this was a CT scan report. So this is typical head injury. I always believe when you are in an emergency department or when you are in a neuro ICU, if suppose you get a call regarding any RTA is coming, you have to listen that call very carefully. Don't just listen that somebody is coming with the road traffic accident, because your history is going to provide you the maximum input for the management. If you do not listen to your history, you do not communicate properly with the person at the other end, you will be in a trouble. And your patient may get delayed support by a specialist. What is mean by that? Whenever any accident comes to you, you have to ask, what is the scene? What is mean by scene? What is the type of the accident? Whether there are it's a car hit and run, or there are multiple car and two-wheelers, or how many casualties are you are expecting? 2, 4, 6, 10, 15. What is the scene at that site? How many are dead? How many are survived? How many are severely traumatic? Accordingly, you have to prepare at your end, emergency department. Like you have to intimate to the blood bank, you have to intimate to the trauma surgeon, you have to intimate to the plastic surgeon, you have to intimate the social worker, administrator, casualty, ICUs for the keeping the bed reserved. So trauma scene is the first part. Second part, suppose there is a 2 or 3 casualties. Out of that, serious one is coming to you. You have to just assess what is the condition of patient, whether he is conscious, unconscious, whether he is intubated, not intubated, and what is expected or anticipated polytrauma. Like our case is giving his hit and run, his unconscious, pupils are 4 mm but reacting to light. There is a rib fracture, but there is no hemothorax, pneumothorax. So I am prepared. I know what I am receiving. So then I will move ahead with management of this thing. If you see, this is just incidence and mortality regarding the different hematomas or the head injury like extradural, subdural, intercanal hematoma. Then there are different scoring scales we use to assess the severity of the trauma, like Glasgow Coma scale or 4 score or Marshall CT scan classification or Rotterdam CT scan. What is the purpose of this score? Purpose of this score is to assess the severity of the patient, to do the prognostication, and when you are dealing with the relatives, it gives you the idea what you are supposed to speak with the relatives on the background of your finding. Like the Glasgow Coma scale, everybody knows that this is still gold standard in management of the traumatic brain injury. It is still gold standard for as a scoring system to do the severity of to assess the severity of the traumatic brain injury as well as for the prognostication. Only issue with the Glasgow Coma scale will be if the patient is intubated. If the patient is intubated, then you calculate it as a E1, so it is not the ideal one to comment regarding scoring system. Then there is a 4 score. See, no need to memorize, just keep those chart ready or those put it on your notice board of the casualty or emergency department. Just go through that. Go through the objective 1, 2, 3, 4, calculate the score. What is the advantage of the 4 score? There is no, even the patient is intubated, you can calculate the proper score. But still, in spite of all the scoring system, Glasgow Coma scale is still gold standard for traumatic brain injury. Then Marshall CT scan classification, again, it's based on the CT scan. Again, if the patient is intubated, it doesn't matter. You can just assess the CT scan, read that, and label your prognostication. And then Rotterdam computed tomography score, again this same on the basis of the different findings on the CT scan. Now coming back to the case, we know our case is 40-year-old male, we know that he is a severely head injury, we know that there is some associated chest trauma there, he is coming to your casualty. Now, before reaching to a casualty, you have to assure that patient should reach to your emergency department in a proper condition. There are only two things remember in pre-hospital care, that is before your emergency department. Intubation, that is hypoxia, and hypotension. These are the only two markers you have to follow during your transport. You have to be continuously in touch with the EMS doctors in casualty, just assess. Now, for example, tube, hypoxia. There is always debate whether to intubate or not to intubate this patient. For example, our patient GCS is 6, he needs intubation. But if I am not sure about my emergency guy in casualty, whether he will be able to do intubation in an ambulance. So there is now enough evidence is available. If you are not expert or not confident regarding intubation in the ambulance, please do not intubate. Do back mask ventilation or go ahead with the laryngeal mask ventilation and reach to the nearby emergency department. If you are confident, if you know your job, if you are expert, then intubation. So there is no much debate now, intubation versus non-intubation. The main issue is avoid hypoxia. Second thing, to drugs which should be used during the intubation. Like midazolam is still gold standard. You can use ketamine. There was an argument regarding ketamine, whether ketamine raised the ICP. Yes, it raised the ICP for a very transient period. But if you see risk against benefit, there is now enough evidence for ketamine. You can use ketamine for doing the intubation in rapid sequence intubation. There's choline. Again, it's a short acting. We always promote the rapid sequence intubation in trauma victims to avoid the bouts of the ICP, raised ICP. Against choline, you have to be careful. Only patient should not have a crush injury. If the patient has a crush injury, then chances of the hyperkalemia are more with the choline. Otherwise, it's a safe drug. So, first part is hypoxia during the pre-hospital care, and second part is hypotension. What is traumatic brain injury guidelines suggest? One event of hypotension during the pre-hospital care or two events in your emergency department are the bad prognostic marker for traumatic brain injury. So you have to just ask what is happening with the blood pressure. Blood pressure is okay. Mean blood pressure is more than 65. Okay. Mean blood pressure is more than 65. Otherwise, that doctor says on arrival that he has drop in BP 70 systolic just 5 minutes before I gave fluid, and again it's come back to 110. So that gives you the idea that probably you are dealing with the severe case of traumatic brain injury or trauma. So when to intubate, there are so many things you can guide you regarding intubation during the pre-hospital care. I am talking about the pre-hospital care. Like patient GCS is less than 8, patient has a facial-maxillary injury, patient has the airway compromise, patient has the intra-oral bleeding, or patient had a compromised airway, patient vomited, and there is a risk of the aspiration. So that AMS person has to be geared up with management of severe head injury or traumatic brain injury during transport. And always assume, it's a dictum, unless until you rule out, there is always cervical spine injury. So whichever the things you are dealing with the patient, please maintain the inline stabilization of cervical spine with whatever the way. Either you can hold it with your with the help of the assistant, you can keep the sandbag, you can keep the hard collar, or do the modified jaw thrust maneuver. Then, okay. Now we know that we have taken care of the hypoxia and hypotension before patient reaches to your casualty. Okay, now he reached to your emergency department. So what the things you are going to see? See again airway, breathing, circulation with management of the cervical spine. Airway, again the same question. If the patient is not intubated during your emergency, your pre-hospital care management, you are going to do intubation. Intubation is again rapid sequence intubation. Already I explained what is meant by that. Then ventilation. If the breathing is inadequate or the patient is sedated or patient is kept under the short paralyzing agent, then patient has to be ventilated. Transient hyperventilation is allowed, but please, hyperventilation in trauma is now outdated. You have to ventilate with the normal ventilation with the concept of the normal apnea. Your CO2 has to be the normal. That is what your aim for ventilation in trauma. Then hypotension. Okay. Generally our target is mean blood pressure more than 65. If the patient has hypertension, you have to correct it. You have to correct it with the crystalloid. Choice of the fluids are crystalloid. Colloids only blood if it is indicated. Otherwise, colloids are contraindicated in resuscitation of the trauma victims because of the risk of the acute kidney injury or because of the coagulopathy. There is a lethal triad. In traumatic brain injury, there is a lethal triad. There is hypercoagulability, there is severe metabolic acidosis and bleeding. So hypothermia. These are the three lethal aspects during the trauma, which may kill that patient. So your colloids may exhibit underlying coagulopathy, so avoid colloids. And then you have to do the primary assessment in terms of detailed injury. Okay, so you did the assessment in terms of the stabilization of the cervical spine, then you did the intubation, you taken care of the ventilation, you are managing the breathing, the circulation part you are taken care, and now moving towards the GCS, that is the Gauss coma scale or neuro assessment. Still I told you the GCS is the gold standard in assessing trauma victims. So GCS gives you the idea whether it is a mild, moderate or severe. So if it is 13 to 15 GCS, it is a mild head injury. If it is 9 to 13, it is a moderate, and less than 8 is a severe head injury. So GCS not only guides you regarding assessment of the severity, it also guides you about your therapeutic interventions. And then investigation. Investigation, of course, you have to say everything along with the coagulogram, because one of the major aspects of the trauma victim is coagulopathy. Okay, now next. You manage the airway, breathing, circulation, cervical spine. Now see, we are moving with the patient. And the things happens like this only. If you try to bypass the thing, then you will be in a trouble. So now after managing the airway, breathing, circulation, cervical spine with the assessment of the neurological condition, you reach to the imaging department. So what are the indications of the CT scan in head injury? There are so many indications of CT scan in head injury. No need to go to the only severe cases require the CT scan. No, even patient comes walking in your casualty with a history of the amnesia or history of the transient loss of consciousness. Please do go ahead with the CT scan. Don't bypass CT scan for the medical legal purpose as well as for scientific purpose. So these are the reasons where you can go ahead with the CT scan in trauma victims. Okay, the next question. After doing the CT scan, when to call neurosurgeon? Actually, neurosurgeons are in picture since emergency department, but generally they are more in action after the scanning. After scanning, you should know when to call neurosurgeon. Ideally, what neurosurgeon does is, honestly, we don't have a control. They decide their intervention this thing. But at least as an intensivist, we should know when to give a priority to the imaging and inform to your colleague neurosurgeon. For example, subdural hematoma. Subdural hematoma, if it is more than 30 ml, or there is a drop in GCS, rapid drop in GCS. Like for example, on admission, the GCS of our patient was 6, and when you reach to the emergency department, GCS dropped to 3 or 4, and there is a CT scan shows subdural hematoma with either 20 ml or 30 ml of volume, then this is the indication he may need intervention. Extradural hematoma, again the same indication. So you have to follow the patient. The drop in GCS and particular amount gives you the idea this patient may get help by neurointervention. Then intracranial hemorrhage, again the indications are same. You have to follow the GCS or volume by the CT scan. Then craniotomy, it's another big deal. Decompressive craniotomy, we are discussing so many times what is the role of the decompressive craniotomy in the neuro cases. There was a DECRA trial in 2012 which was negative. The first trial in 2012 was negative regarding the decompressive craniotomy, and then in 2016 there was another trial came, and which was a rescue ICP. This was a rescue ICP trial, was a positive. This was the first positive trial in traumatic brain injury regarding the decompressive craniotomy. But when you are reading such papers, you have to read it very carefully. What do you mean by that? If you see, there is a straightforward benefit of mortality. In a rescue ICP trial, your mortality rate dropped down to 26% as compared to the 48. It's a quite significant amount of the mortality benefit. But then you have to read the next one. What is that? You are creating vegetative bodies. 2.1 versus 8.5. Believe me, when I started 2002 neurological care unit or neurotrauma unit in Ruby Hall, one of my senior neurosurgeon was a brigadier Dr. Vajpayee, came to me and said that Dr. Jirpe, you are doing the fantastic job, you are young, you are enthusiastic, you are going to save so many young patients, but please note down, you are going to create a vegetative bodies also. And at that time I thought he is an old person, he must be not very aggressive enough for the management of head injury. Now after 18 years or 16 years I realized that what he say was an experience. So no doubt it helps in a mortality, but then India is a resource limited country. We know that our patients are paying from our pocket. So what we achieve by saving those lives at the cost of the 5-6 family members, because they sell their lands, they sell their every property to save that young chap. Unfortunately, majority of the trauma victims are young victims. So that is what the advantage and disadvantage of such a fancy intervention. But this is the first positive trial in 2016 in favor of the decompressive craniotomy in the trauma victims. And this was the comparison. If you compare the DECRA versus rescue ICP, there is a difference is that rescue ICP was they either done the unilateral or bilateral, but in DECRA did the bilateral. The major difference was the ICP threshold. If you see the ICP threshold in DECRA it was 20 and ICP threshold in rescue ICP was 25. What do you mean by that? Probably in rescue ICP patients where consider for the decompressive craniotomy when all other measures have been tried, like tier 1, tier 2, like you can do the position benefit to the patient for reducing ICP, do the proper ventilation, give the osmolar therapy and manage those patients aggressively for reducing the ICP, and in spite of that tier 1 and tier 2 therapy, if the patient deteriorates or ICP is raising about 25, then so probably there is an adequate period given before decompressive craniotomy, and that must have been landed in benefits regarding the rescue ICP. Again, it's a debate. Still, there is a debate is going on regarding the decompressive craniotomy. But at least in 2016 or 2018, now we have evidence for decompressive craniotomy is a positive one for traumatic brain injury. Then penetrating injury, surgical part. If that object is causing intracranial hemorrhage or GCS is dropping or further raise ICP, then only you can remove that penetrating object. Depressed skull fracture, if that skull bone is depressed by thickness of that bone is one of the indication for lifting that bone and going for the surgical intervention, or it is causing the inside intracranial hemorrhage. Okay, that is the reason, then you can go ahead with surgical part. Okay, next part is ICP. Now see, try and understand, now patient is coming to the your ICU. Up till now, since the last 10 minutes we are discussing the management of the major management of trauma victims happens in emergency departments and the radiology department or imaging. Patient reaches to the ICU only after when neurosurgeon says that there is no indication of now neurosurgical management, active neurosurgical management, shift the patient to the ICU and manage ICP. Then patient is in ICU. So please don't waste time in shifting your patients to the ICU on a priority. Just do every management aspect of the traumatic brain injury and come to your ICU. Now in ICU, what is the major deal with the traumatic brain injury management in ICU? The ICP monitoring. So what is ICP monitoring? Like for example, the major part in the skull bone is the brain. It's a rigid structure. Inside that there is a brain, there is a CSF, there is a venous blood, there is a arterial blood. So in normal situation, it's okay. They are sitting there comfortably. But when anything happens to the brain, like bleed or hematoma or contusion, that brain swells. That means the edema is occur. Then where is the space? The skull is a rigid factor. So where is the space? What they will do? They will compress the easily compressible part, like CSF and venous blood. And that is what this picture is giving you the idea. Okay, when there is anything bleed or contusion, they will compress CSF and venous blood plus. And in spite of that, if suppose still your ICP is raising, then it will cause the pressure on the brain and land with the cloning. So to avoid that, you may go ahead with the further therapies to do the ICP monitoring. Like what is the ICP monitoring? Actually, you are interested in managing the cerebral perfusion pressure, that is the CPP. How you manage the CPP? It is mean arterial blood pressure minus ICP. So your target of CPP is 50 to 70 millimeter of mercury. If your CPP is going high, either you have to raise the systolic blood pressure or you have to reduce the ICP. So what is target of the systolic blood pressure in trauma is more than 65. If suppose in spite of the adequate fluid management, your mean blood pressure is not coming more than 65, start normal. Or you reduce your ICP. It is less than 20, but even now you can go up to the 22. When you say 22 is your threshold for ICP for going for the further intervention. What is the indication for ICP? Straightforward. GCS less than 8 with abnormal CT scan. Like in our patient, there was an abnormal CT scan. It was a straightaway indication for ICP monitoring if surgeons are not going for the decompressive craniotomy. In other situation, GCS is less than 8, but CT scan is normal because there is no hematoma. Might be he has a shear injuries or axonal injuries. In such situations, the clinical things comes into picture. If your GCS is less than 8 with the CT scan normal, you have to see the 3 parts like age more than 40, or he is a decerebrated posture, or there is a hypotension. Any 2 out of 3 are present, go ahead with ICP monitoring. No need to wait for MRI and document that he has a severe underlying shear injuries. Exclusion criteria as usual for any procedure, they are the same for ICP. Then different ways, like you can go at the intraparenchymal, you can go to the subdural, you can go to the intraventricular. Out of that, intraventricular drain is the most popular because it is easy to do, it is bedside, it is possible. Second thing, it is not only diagnostic, it is for therapeutic also. If you put the intraventricular ICP monitoring, if suppose your ICP is more than 22 and you are doing maximum with your medical management, then just drain the CSF. If you can drain the CSF, just check the ICP, it is coming down less than 22, again block that catheter. So, intraventricular ICP monitoring is helpful in diagnostic as well as therapeutic management. What is the problem with the intraventricular ICP monitoring? Problem is infection. Infection rates are so high in Indian ICUs, the neurosurgeon as well as everyone is concerned about the infection. So, that's why this technique is easily available, better to do, but one of the drawback or the major concern with this therapy will be the infection rates. Waveforms, I am not ideal, sorry to say, but our center is not doing it regularly, ICP monitoring. But this ICP monitoring like your intra-arterial blood pressure management, that waveforms give you the idea of what is happening with your patient. Okay. I don't have the invasive intracranial pressure monitoring system. It's okay, it doesn't matter. You can go ahead with the non-invasive methods of diagnosing the raised ICP. These are now getting more and more popular because see, in India, if you see the multimodal neuromonitoring system, we are very poor followers of that. Every conference we speaks about that, but hardly there are anyone follows this technique. So these non-invasive are gaining more and more popularity because you don't require any neurosurgeon or surgical team for that. Cost-wise it is okay, infection rate is not a major issue with this technology, and it is bedside possible, and we intensivists can do that. So that's why those are getting more popular, like transcranial Doppler or optic nerve sheath diameter and the other techniques, but they are not very much proven to beneficial in management. And this was a recent paper in 2018 which was talking about the optic nerve sheath diameter is one of the promisable technique, now emerging as a promisable technique in diagnosing your raised ICP bedside. Okay, now you are done with the ICP, you know the ICP concept, you are managing the ICP, then how to reduce the ICP? The simple technique, you have to make the bed propped up 45 degree, then you have to keep sedated, and if required paralyze the patient, that means the normal ventilation with the normocapnia. Then if there is a ventricular drain, do the CSF drain. And the fourth part is the osmolotherapy. Now there is again frequently asked question. There are two drugs, mannitol versus hypertonic saline. Mannitol 1 gram per kg bolus followed by 0.2 milligram per kg. You have to monitor the serum osmolality. If your serum osmolality is less than 320, then only give the next dose. So don't ask me the question at the end of the lecture, what is the dose of the mannitol. Mannitol dose is as per the serum osmolality. Second part is the hypertonic saline. Again that is a frequently asked question. Now there is adequate evidence is available for the hypertonic saline. It's a 3%, 250 ml over half an hour you can give. You can try 7.5%, you can try 23%, but now easily available is 3% and less complicated. What you have to monitor during hypertonic saline? Serum sodium level. If there is hypernatremia, you have to be careful with your hypertonic saline. Then I always say the analgesia and sedation is the art in management of the trauma patient. You see, there are sedatives, there are hypnotic, and there are analgesic. Few drugs are sedatives and analgesic. Few drugs are sedative, analgesic plus hypnotic. I have to choose my drug. Like in trauma victim, they are always associated with the polytrauma. So pure sedation will not be the choice of drug in my management of the ventilated patients in trauma. If I add them with the sedation plus analgesia, my requirement of sedation will come down. So they need the good analgesia and proper sedation. So which are the drug of choice? Drug of choice is either fentanyl or midazolam or propofol. I never use midazolam alone unless and until I am quite sure there is no polytrauma. But it is very rare in a traumatic brain injury. You will get the isolated traumatic brain injury without any trauma. They have the blunt trauma, they have abrasions, there are so many other things are there. So generally choice is either fentanyl plus midazolam or propofol plus midazolam. Please don't memorize the doses. Put it on your notice board. I don't know the dose of any drug. I always follow the smartphone for calculating my doses. Then ICU care. Okay, now you are managing the ICU, you manage the sedation. What is ICU care? Faster. What is it? There is nothing different in trauma victims. Like you have to follow the nutrition, you have to follow the DVT prophylaxis, you have to follow your ulcer prophylaxis, you have to follow the rest of the management. Enteral nutrition, again it's a hypercatabolism rate, it is 35 kilocalories per kg is a dose, high protein. Sugar is bad for the brain, no need to emphasis on that, so avoid hyperglycemia and hypoglycemia. Now frequently asked question, role of the hypothermia. There is no role of hypothermia in management of traumatic brain injury. Even in 2018 trial about the traumatic brain injury in hypothermia, it is negative. Steroids, there is no role of steroids in traumatic brain injury. Then neuroprotective treatment, there is no role of the neuroprotective treatment in management of traumatic brain injury. What are the risks? Now, one of the major concerns with the traumatic brain injury is a seizure. So, which are the risks for the post-traumatic seizures? This is a list. There is a change in GCS, there is a sometimes there is an early seizure, sometimes there is a late seizure, there are penetrating injuries, they may provoke the seizures, or there is a infection or associated alcoholism. Seizure prophylaxis, again frequently asked question, only early seizure prophylaxis is acceptable in trauma, there is no role for the late seizure prophylaxis. Drug of choice are either iptoin or fosfomycin, and nowadays we are using the levetiracetam. Neuromonitoring. What is the role of the neuromonitoring? I already explained you what is meant by the neuromonitoring in trauma. Now we are talking about the multimodal neuromonitoring. What do you mean by multimodal neuromonitoring? If you see in a trauma victim, first 24 hours, 40% of the traumatic brain injury patient shows clinical relief neuronal. So your first day is crucial. Second thing, volume of hemorrhage may increase up to 42%. So maximum happenings happens in 24 to 48 hours, and that's why you need to have certain other techniques to pick up those early deterioration. So which are these advanced neuromonitoring, like jugular venous oximetry? You have to put a catheter into the jugular vein, and you have to measure the this oxygen saturation, mixed oxygen saturation. If it is less than 60%, there is a chance of the hypoxic anoxic injury to the brain. Or measure the brain tissue oxygenation. Again, you have to put a catheter like ICP into the interparenchymal situation. You have to measure. If it is less than 20, your chances of the hypoxic anoxic damage to the brain are more. Or you can do the cerebral microdialysis, or you can do the thermal diffusion. These are the new technique. These are the advanced technique. And I told you the timing is first 24 to 48 hours because the maximum deterioration in traumatic brain injury happens within first 48 hours. Prognosis. Always, see, these are all young victims. This is a huge financial related. Families are always behind us. What is the prognosis of my patient? So you should know which are the things should be considered for prognostication, like age, your images, your imaging findings, your pupillary reaction, their size, their movement. Then you can go ahead with the hypoxia, how many hypoxia events happen, how many hypotension events happen. So these are the parameters may guide you for the prognostication. But if somebody asks you the proper prognostication, there are the two models are available. One is the impact prognostic model, and second is the crash. Again, they are on the basis of the what I already explained in the previous slide. You can calculate those parameters, put them into your scaling system, and just see whether this patient has a bad prognosis or good prognosis. Like what is the impact prognostic model? There is three models, again the core or extended model or laboratory model. So they are just adding the parameters. Like basic model has age, motor score, and the pupillary reaction. That gives you the idea that this patient is going to have a severe this thing. If suppose that is having dilemma or it's the borderline scoring system, you can add further hypotension, hypoxia events, and the CT scan finding. Still you want to be the more accurate, then add the lab findings and the other findings to give you the idea whether this patient is likely to be more and more vegetative stage, or he is not going to survive, or is going to survive. In crash model, again it based on the those parameters only. Again, there are the 4 variables and 5 variables, and that gives you the idea regarding which way you are heading. So to summarize, management of traumatic brain injury, prevention of the hypoxia and hypotension before emergency department arrival, that is the pre-hospital care, is a priority. Then use normal saline crystallite for the resuscitation, surgical evacuation as per your guidelines. Treatment of elevated ICP, your target is, here I am given 20, but now we are following the 22 is the ICP threshold. Sedatives is individualized, it's an art, you have to make the combinations. Early prophylaxis, seizure prophylaxis, yes. Late, no. Thromboprophylaxis, yes. If you are not going ahead with any surgical intervention, or if there is no major hematoma, you can go ahead within 24 hours or after 24 hours. And there is no role of steroids in traumatic brain injury. Thank you. Thank you.